She is Ayurvedic food consultant and Ayurvedic recipe developer, consultant surgeon in Sheikh Tarachand Hospital since 2014 till date, and she is doing her private practice and consultancy. Speciality is Shalya Tantra. She has his specialty in Kshar Karma, Vidya Karma, Agni Karma as well as anorectal disease. During her graduation time, she has worked with respected Yaga Joshi sir, Narendra Pense sir, Ramesh Nanal sir as well as R.B. Gopte sir. So with vast theoretical as well as practical knowledge, and she is now currently working in reputed Tilak Hospital. So we will surely know from her that which all Aushadhi Kalpana are used in Arsha Vyadhi. As well as she was my colleague and my good friend from Poddar. So I will request Dr. Rashmi to continue his talk on Arsha and Aushadhi Kalpana.
Thank you, Dr. Chintan, for the wonderful introduction. First of all, I would like to thank you, Shreyas E-Learning Academy, for giving me an opportunity to share my thoughts on Arsha. I'm a practicing consultant surgeon in concerned field. Dr. Chintan has already introduced me with his kind words. So we should start with our lecture today. Okay. So the topic is Arsha and Aushadhi Kalpana. Before going to the topic, I definitely need to clear that the Arsha is a thing which is basically identified in a clinical practices, where day-to-day practice you get to know all these Arsha patients in different kind of scenarios. Okay. When the patient comes to you to the OPD, the first complaint of the patient is piles. Okay, डॉक्टर क्या हो जी बताइए आपको क्या होता है. Patient always comes to, like other disease, every disease has its specific, what we can say, chief complaint. But the only in all these year of practices, what I have learned that piles has no complaint, only piles is a complaint. Every patient comes to you, जी piles का तकलीफ है. So the vast variety of anorectal diseases come to the one word called piles. But as being a practitioner, I would definitely say that not every anorectal complaint is a piles. Okay, piles is a generalized term which is used by so many peoples. But being a proctologist or being a vaidya or being a doctor, you have to differentiate all these things, all these complaint, and identify what is the root behind all this. So we'll start. How to differentiate all the one complaint of pile into different kind of anorectal disease. Today we are dealing with hemorrhoids only, but the thing is, patiently listen to all complaints, whether it's PR bleeding, whether it's pain. Patient comes to, basically anorectal disease has many chronicities. जो patient आता है आपके पास, यूजुअली ऐसा होता है कि काफी क्रॉनिक कंप्लेंट्स के बाद पेशेंट आपके पास आता है, and the only complaint he has taken OTC for the complaints. कुछ तो लिया होता है, and unbearable, when the complaints are unbearable, then only patient comes to you. So first thing you have to do is patiently listen what is the complaint. So we'll just check out what complaints usually patient comes to you. Pain, perianal pain, generalized perianal pain, localized perianal pain, anal canal pain. So basically the pain, when the pain get worsen, patient comes to you. Only those patient where with unbearable pain usually comes to OPD and visit, or they are rarely acknowledge the complaint of pain. Okay, so whether so the first thing of when you sit in a OPD, first thing you have to listen the complaint very patiently, because all the diagnoses are hidden in the complaints only. Okay, when the pain, perianal pain, generalized pain, perianal pain is there, there should be a query of generally pain is a complaint is related with fissure in ano. Bleeding PR is the chief complaint which we have to look into the hemorrhoid complaint. Prolapsing tissue is also related with hemorrhoidal complaint. Something coming out of anal canal is also either whether it's a sentinel tag or either it's a prolapsing hemorrhoid. So we have to think about when the patient tells you the complaint, we shall start thinking in the mind what be the cause before examining locally. So another complaint which is very commonly observed in some patient, that is pruritus. It's a we can say it's a beginning of the anorectal symptoms which started. The pruritus is very common amongst all anorectal diseases. We can say it's very common in fissure in ano. It's very common in hemorrhoids. It's very common in fistula in ano, because all the chief complaint pruritus is very common among all anorectal patients. The perianal discharge, whether it's from the periphery, whether it's from the anal canal, we have to assess these things and keep in mind that we have to listen patiently all the complaints of the patient. Then we need to assess the chief complaints, because the chief complaints guides us where actually the diagnosis goes. If it's only PR bleeding, hello, yes.
Madam, are you moving the slides?
No, I'm not moving the slides.
Okay. Okay, sorry to disturb you because slides were not moving. I thought you were moving the slides.
Which slide you are able to see?
The first one.
Okay. No, first one. Yes, I am moving the slide. I am on slide. Second slide. I am on.
Okay, madam. It is not moving. Sorry to disturb you, but just to let you know.
Not a problem. Not a problem. Shall I stop sharing and start again?
Yeah, you may
try to make it whole full screen. Then the slides may move.
Yes, sir. It's in the full screen. Actually, I am on a full screen only. The only thing is, I guess there is something technical issue arising, because now I am moving slide. Are you able to see the moving slides over here?
No, the slides are not being moved yet.
Okay. Let me. I shall stop sharing now, and we'll begin again. Because I am moving the slides now, and you are not able to see that. There must be a problem then. Just a second, please hold. Okay, now I have stopped sharing. I'll share it again. Okay. Are you able to see the slides are moving? Hello?
Yeah, the second slide is the slide. The current slide is second. Can you
Okay,
try
now
moving?
I am on the third slide and fourth slide. I don't know what is happening. I shall share once again. Now it's the third slide. Are you able to see the differentiation one?
No, not yet. Madam, we'll just try logging out once and then log in again.
Okay,
Then-
sure.
Yeah.
Okay.
Yes, madam, you can share the screen now. Hello, you are not audible, madam, yet. Hello, madam, your voice is not audible. No, not yet.
Hello. Am I
Yes.
audible now?
Yes, now you're audible. You just
Okay.
try sharing.
I'll just quickly share the screen and we shall start. Everyone is able to see the screen now?
Yes, the screen is visible.
Okay, now I'll just check whether the slides are moving or not.
Yeah, before that,
Are they
madam,
moving?
can you make it to slideshow?
Yes, I did that. I mean, I am able to see the slideshow.
Okay.
You just confirm whether the slides are moving and your view is in the slideshow.
No, the slides are not moving yet. It's a first slide right now.
Shall I mail you the my presentation? It would be better because I guess there is a technical issue because I am able to see the slides are moving. I am going slide by slide. Okay, but I don't know. Unfortunately, at your side, the slides aren't moving, and you are not able to see the slides are moving.
Fine. You just mail to Dr. Chintan. Then
Okay.
we just from him.
One thing we can do, I'll stop sharing and we'll start by new. You just let me know whether the slides are moving and the presentation is in full mode. I have stopped sharing now, and I am again I'm sharing. If it doesn't work, I'll definitely mail and we'll do that like that only. And okay, see, and now I'm sharing. I have created a full screen sharing.
Yes. Now the second slide is visible. Differentiation.
Okay. Please check whether the slides are moving or not. Are you able to see the moving slides now?
We are on slide number 4.
Yeah, only slide number 4 is visible. Okay, because I am moving the slide now. I am on the slide 7. I can see the local examination slide on my side. What's your slide over there?
No, it's still on the differentiation slide.
Okay, the thing is, when I'm moving the slide, it's only up to me. The slides aren't moving to your side. Right?
Okay. Yeah.
Okay. Okay, the one thing we can do, I'll just mail it and you run the slideshow on your side and I'll dictate. Okay, is that fine?
Fine.
Yeah. Can we wait for some time? Just 5 minutes more?
Yes.
Yeah. To the listeners, sincere apologies for the inconveniences. We shall start soon. Okay, the presentation is reached and visible to everyone now.
Dr. Rashmi, it is visible to everyone. You can
Yes.
continue and just this. Okay.
Yes, sure. Thank you, Dr. Chintan. Okay, so as I have said that patiently listen to the all complaints. What patient have come to you with complaints. These those complaints needs to acknowledge first what is the chief complaint. Then you need to assess the chief complaints, whether it's painless PR bleeding or it's a painful PR bleeding, whether the pain is associated with any other mucus discharge, whether the pain is associated with other complaints like pus discharge, whether the pain is associated with any other complaints, pruritus. So these complaints we need to assess and acknowledge properly. Then we shall go to, then we can think of what would be the final diagnosis of that anorectal complaint. Okay, the thing is, when patient comes to you and put forward the complaints to you, your half diagnosis has been done, because as all of you might be aware of that painless bleeding is a classical entity which is seen in hemorrhoids. The hemorrhoidal PR bleeding is always associated with a splash of blood in a pan. Not necessarily if there are internal hemorrhoids only, you can see these complaints classically those who have internal hemorrhoids with either of a second degree, either of a third degree. Those who have first or second degree hemorrhoids may not come with these complaints, but when there is a painless bleeding, one must, or a doctor or a Vaidya must think of a hemorrhoidal complaint. When there is a pain with a PR bleeding, there should be a fissure, because fissure is always associated with a pain sort of complaint. Okay, just a second. Okay, so do not rush. Sorry for the disturbances. Do not rush on the conclusion on one complaint. Like only PR bleeding, do not rush for the complaint. Do not rush for the diagnosis of either hemorrhoid or the fissure. Just always assess all the complaints, all the what we can say etiological factor behind it. Then go for a conclusion whether this would be a diagnosis. And very importantly, examine locally. The only thing in anorectal diseases, I have seen that patient usually hesitate to show what the disease condition. You might have seen in the OPDs where a patient only tells you that I have an anorectal complaint, and an anorectal complaint in form of I have a mulvyad. Okay, in Marathi, usually patient comes to us and say Mala mulvyad hai. Okay, so the only one thing mulvyad or one thing pile is not the only thing. You have to examine the patient locally, whether it's a fissure, whether it's a hemorrhoid, whether it's a fistula in ano. The only I would what we can say, this is a thumb rule of examine or taking a case of any anorectal patient is to examine locally, because the disease entity itself say a lot with patient's complaint, but only when you examine locally you can assess what exactly at that place. Okay, so I would say the thumb rule to examine patient locally and then come to the conclusion what exactly the disease is. Can we move to the next slide?
Yes.
I'm still able to view the same slide. Is the slide has moved? Yeah. So we have seen these common complaints before. For your just to revise them, I have put them forward. Okay, the next slide. So okay, I have read them already when the slides were not moving on your side. Still I read them. The pain, perianal pain, generalized pain. Okay, not a problem. So what we need to examine in a local examination, you can see I have put a picture over here that the anal verge, we can say the lower part. Okay, the lower part in at anal verge, we can see the lower part. What kind of pathology is over there? There must be some for what folliculitis must be there. A folliculitis has begun with a small abscess or a boil, we can say. So the lower margin, lowest margin has to we have to see, that is a anal verge. What you have to see on the perineum, is there any abscess, is there any kind of ulceration form, any kind of discoloration, whether it's red color in discoloration, it is blackish color in discoloration. These things we need to assess. Okay, these things actually help us to conclude what is the diagnosis. Okay, so when we see the perineum, we have to see for ulceration. Anal verge is classically examined for fissure. Fissures are usually present at the anal verge. Okay, so when the fissure is present, usually what happens, there are chances of getting fissure and hemorrhoid together. In these cases, you are not able to do the per rectal examination, because per rectal examination is contraindicated in fissure patient. Those patients were complained that I have a streak of blood on stool. With that also, I have splash in a pan also. In this cases, then your what we can say thorough listening of complaint will help you to diagnose. Okay, if you are able to see a fissure on the anal verge, and the patient is complaining that I usually see drop by drop blood is in the pan, then you must think of that there is a fissure also and there is a hemorrhoid also. So these two conditions can coexist. Okay, so we need to assess first, then that's why the local examination is really very important. So when we assess a perineum for any other swelling, any other discharging sinus, we have to assess all these area for all these complaints. Okay, as I have said that fissure and hemorrhoid can coexist. Similarly, fistula and hemorrhoid can also coexist, because I have operated several cases where the fistula is there, and you can see that hemorrhoid is also present. So one thing you have to do, a Shara Sutra also, and you have to do a closed hemorrhoidectomy also, or open hemorrhoidectomy also. So these things and these cases are usually coexist, because all the patients comes to you are very very chronic, and in that chronic condition, patient usually delays his treatment, delays his or her treatment, in spite of all what we can say available medical facilities, just because of hesitation to showing someone what we can say, showing someone to see what exactly the cause of that pain or that complaint. Okay, then we would come to per rectum or digital rectal examination. Okay, so the digital rectal examination, what it shows, usually there are so many we can say we can say the digital rectal examination gives us exactly what is the condition of the spasm and the chronicity of the disease. If I ask the question to PG student, did you felt the hemorrhoid when you do the digital rectal examination? Because the hemorrhoid is an entity where the venous plexus is enlarged, and when you press the venous plexus, there is hardly to get any swelling on a digital rectal examination if the hemorrhoid is present. So digital rectal examination is to assess the chronicity and spasm of that area. Okay, but it is really very important, because before you introduce a speculum, that is very important to go digital rectal examination with the help of LOX 2% jelly. and then go for a per speculum examination. A digital rectal examination also helps in diagnose other conditions such as whether the dimpling is present or not, when the fistula is there, other like BPH. I mean, you can diagnose BPH in male patients for such conditions. So then we go for a per speculum examination. Hemorrhoids is the only entity which can be which can be visualized with per speculum only. You cannot diagnose precisely when they are internal hemorrhoids. External hemorrhoids, you can see them on the anal verge, because the external hemorrhoid you can see in this that they are below the Hilton's line. Okay, so you are able to see the hemorrhoids which are external hemorrhoids. We are going to see the differentiation between external and internal hemorrhoids when we move forward to the next slide. But you need to understand that hemorrhoid is the entity which can be seen only on per speculum examination. Okay, so final diagnosis of the hemorrhoid shall always be after your digital rectal examination. Okay, now the hemorrhoids, how to study the hemorrhoid. We will see definition, etiology and risk factor, types and classification, clinical picture and differential diagnosis and treatment of the hemorrhoids. Next please. Okay, so what is hemorrhoid? Basically a hemorrhoid is means blood flow in a Greek. Haima is blood and Roya means flow. Okay, the hemorrhoids are defined as symptomatic enlargement and distal displacement of normal anal cushion. So the anal cushion is made up of what we can say venules, arterioles and capillaries. This is the anal cushion is made up of. Have you heard of chronic venous insufficiencies? The hemorrhoid is a part of chronic venous insufficiencies. In other parts of body where the chronic insufficiencies happen, these are, next slide please. There are 4 types of chronic venous insufficiencies are common to see. Before moving to that, we shall see the Ayurvedic point of view of Arsha. So everyone knows that the Arivata Pranan Shrunati Hinati Iti Arshaha. So Arsha is nothing but we can say that Arivata Pranan. Ari is nothing but a saw, cutting saw. The pain is similar to a cutting saw. Hence, we can say it's a comparison of a pain which is Arivata Pranan Shrunati. It is also called as a Mausa Kilak because as its appearance would say that Mausa Kilak, it felt a feeling of what we can say Mausa, or feeling of something which is coming out of anal region. Durnama is the other name which is given by Vagbhat. So the anatomical terminologies are Uttaraguda, Adharaguda, and where the Purisha is Purisha Avatishthate, Purisha, what is the purpose of Uttaraguda and Adharaguda, that is Purisha Avatishthate and Purisha Nishkramati. So these things will help you when you are totally giving an Ayurvedic medicine. I'll come to that. Why I have mentioned these things and these terminologies over there, because there's a relationship of what we can say all these karma of that particular organ, Uttaraguda and Adharaguda. So the what we can say Gaja Talu Nibhascha Api Varanitaha. So the normal color of anal region is Gaja Talu Nibha. When the disease entity happens, even with Ayurveda, when you what we can say discriminate all these Vata Pitta Kapha types of Arsha, there is also changes in color of that Arsha, and which we are actually able to see on a OPD basis, where the whether it is Vatas, whether it is Pittas or it is Kaphas. Okay, we shall see how to differentiate them. And the reason of mentioning all Pravahini, Visarjani, and Savarani, all the snayu over in the anal canal. This is also related with when you give treatment. All these mentioned things helps you to finalize your medicine, what can be given and what can be done with the patient. We shall see afterwards. But all these things you need to keep in mind when the patient comes to you. Even you diagnose it in a modern way, and the what we can say, the idea of giving medicine, because I think there is no differentiation. The patient should feel better, whether it's a modern medicine or whether it's Ayurvedic medicine. The idea behind giving medicine is the patient should feel better and improvise, and the condition shouldn't worse, and patient should feel better and better for a longer period of time. Next, please. We were on chronic venous insufficiencies. I think the slide is on the next to this. We shall see. Okay, next slide, please. Okay, to understand what there is an echo towards my side. Okay, so to understand what is chronic venous insufficiency, we just have a quick view of chronic venous insufficiency. Any risk factor that cause chronic venous insufficiency, this will cause an increased venous pressure. It will dilate a venous wall or venual wall, and stretching of valves, valvular incompetence will happen, and reversal blood flow and failure of muscle pump to blood, and the vein will be distended, elongated, tortuous, pouched, inelastic, and friable. Are you familiar with this kind of pathology with another disease? Yes, absolutely. This is quite similar pathology which is happen in a varicose vein. So varicose vein is nothing but chronic venous insufficiency when the same what we can say surgical pathology happens to anal cushion of vein. This is also a type of chronic venous insufficiency. The fourth thing actually comes under chronic venous insufficiency, that are first is varicose vein, another one is varicocele, if you have seen varicocele. Other thing is esophageal varices, and the fourth and foremost thing is hemorrhoids. So the hemorrhoids are nothing but the chronic venous insufficiencies. So when you understand the idea behind, even though when you treat patient ayurvedically, many of our fellow Vaidya are still on the when the chronic venous insufficiency is kept in mind, there is always a relationship with the vata rakta. Okay, people who treat all these chronic venous insufficiency as a vata rakta have get tremendous results. So to keep in mind all these things, I have just put forward the theory of chronic venous insufficiency. Okay, shall we move forward for the next slide? So we can see the all four chronic venous insufficiencies. Okay. Okay, I think you have to click on the enter button to see all the pictures I have put on the slide. Anyone from the organizer side? I request you to please once again tap on the enter tab, so everyone can see the chronic venous insufficiency slide. Everyone is able to see the pictures, because I am not able to see the pictures that and the next four thing which I have mentioned, that varicocele, varicose vein, hemorrhoids, and esophageal varices are the four variants of chronic venous insufficiency. Okay, now I am able to see only varicose vein. I think you have to press the tab for several times unless the all content of the yes. So you are able to see the varicose veins in legs. So this is a chronic venous insufficiency. Next is hemorrhoids. Okay. The another thing is varicocele. This is also comes under chronic venous insufficiencies. And other one is esophageal varices. Okay, hope you have understood what is chronic venous insufficiency. So this concept is a very what we can say concise. Only the different form of the same disease entity happens in the body at a different sites. So these things you need to keep in mind when you diagnose and when you prescribe anything, because the basic what we can say modern medicine has based its treatment, what we can say medicinal treatment, on these principles only. Okay, please next slide, please. Next slide. Okay. So, as I have said before, the chronic venous insufficiency, this is a one form, hemorrhoid is a one form of CVA. So, hemorrhoids are cushion of submucosal tissue containing venules, arterioles, and smooth muscle fibers. Okay. So, these are located on a left lateral, right anterior, and right posterior. This normal tissue protects the sphincter during defecation and permits the complete closure of the anus during rest. So this is the main reason where risk factor arises. There is constipation, pregnancy, increased pelvic pressure, ascites, tumors, portal hypertension can lead to this protective sphincter during defecation and during rest. So if the pressure increases, ultimately these things as a precursor will definitely increase. Okay, on the next slide we shall see that what is left lateral, right anterior and right posterior. When you examine a patient on a left lateral position, you are not exactly able to assess what is 3-7-11, why the hemorrhoids arises at 3-7-11. When you say left lateral, it's a 3 o'clock position hemorrhoid. When you say right anterior, it's a 11 o'clock hemorrhoid, and when you say right posterior, it's 7 o'clock. So usually there are question from a question arises why these are the common site of what we can say hemorrhoids. Our hemorrhoids can be seen on the other side. Rarely there are chances of getting 12 o'clock or 6 o'clock hemorrhoid, but there was one older edition of Hamilton Bailey which has mentioned that this cushion is thinnest, naturally thinnest at these regions. That's why the what we can say the force would able to invade the natural mucosa, and all the cushion comes out in forms of what we can say enlarged and tortuous veins. So the 3 o'clock, 7 o'clock, and 11 o'clock are the naturally thinnest, have the naturally thinnest submucosa over there. Hence, usually we can say in 90%, 90 to 99% of patient comes to you on these natural position of what we can say hemorrhoids. Next slide, please. Okay, so you can see over here. So arrangement of piles is usually happens to be on these particular sites. There are rarest forms of arising another forms, because the plexuses are more on these side, and the thinnest submucosa is usually invades the space and comes out of it. So next slide, please. Now you will able to understand what is the specific site of this. Okay, so now we shall move forward. What are the types of hemorrhoid? That is external, internal, and internal-external. So external hemorrhoid are usually just as I have said. This is also same as a venous plexus, but the submucosa is not there. We have seen in the anatomy that submucosa is not about what we can say on the anal verge. There is a mostly mucocutaneous side. Okay, I mean the where the cutaneous and mucosa and cutaneum are comes together at the anal verge. On that side, usually the cutaneous side is more stretchable and more flexible. Hence, the venules or enlarged or tortuous venules try to stretch the skin part most probably. Hence, the external hemorrhoid are not that what we can say not bleeding piles. Usually, when you see a external hemorrhoid, it's not a bleeding pile because of intact layer of skin over that. Okay, it's always on a cutaneous side. Instead of that, when you see an internal hemorrhoid, submucosa is a thinnest layer. Even with a hard stool, trauma of a hard stool, you will see the bleeding, because you can see the passage over here. When the hard stool comes and what we can say create a trauma to that lobulated thing or a pouch like thing which is hemorrhoid, the smallest trauma of hard stool can cause bleeding. So reason behind the bleeding to internal hemorrhoid is any trauma. Usually the trauma is because of that hard stool. Okay, I hope everybody is able to understand. And there is another variant which is also called as internal external. So we can see both internal and external hemorrhoids can coexist together. Okay, so these are the three variants which are usually happen to be present in your OPDs, you are able to see. So as I said before, that these things are only and only examinable when you locally examine. The per speculum examination will only give you the clear picture of what the disease is. So only on the basis of complaints you will not able to assess what exactly the disease entity is. Okay, shall we move to the next slide, please? Okay, so after that, we must learn that there are different types of hemorrhoids mentioned in Ayurveda also. These are Vataj, Pittach, Kafaj, Sannipatach, and Sahaj. Okay, when the patient comes to you in a OPD, yes, there we are able to assess. But these Vataj, Pittach, and Kafaj variants, when the what we can say the hemorrhoidal degree is above 4th degree, then only you can assess whether the